I'm leading for the last 10 years the French reference center on esophageal atresia. So we were quite lucky in France that the Ministry of Health 10 years ago launched a specific call for rare disease and helped to organize things in France with reference center, competence center, and try to organize care for rare disease. Not only esophageal atresia, we are the reference center for France, but you have the same reference center for each Hirschsprung disease, each rare disease, cardiac disease, kidney disease. And thanks to this initiative, we start in France to organize nationally with a network with the aim to have the same level of care, the same level of knowledge every place a child is born, and to have place for discussing recommendation, research, protocol, and also register. We started a population-based register 9 years ago in France. So that gave me the opportunity, give us, all the team, the opportunity to start to have collaboration with other countries, other centers. And what I can say is, except for some countries, Finland, also Australia, where they already start to work together and try to have national reference center or national organizations. What was available in terms of recommendation, research, results, care, were from high-tech tertiary center where they combine very specific and mostly difficult cases. And as esophageal atresia is a very rare disease, each year in France, thanks to our register, there are 160 new cases of esophageal atresia in every place of France, which is quite the same country according to the number of inhabitants than UK. So one single center, even if it's big, even if it's centralized, a lot of patients cannot go on with recommendation, with research, with real data, helping the care of the patients. That's why there have been initiatives, and I was happy to participate to some of them, and to try to merge, to join international efforts to try to pool expertise and development about guidelines, but also about care, about research, about patients with esophageal atresia. So just to illustrate the need of collaborative research in esophageal atresia, there was last year a wonderful world meeting about esophageal atresia, where a lot of people were attendees. And I just have a look and count the number of abstracts, research and result of research that were shown during this meeting. And as you can see here, there was 78 abstracts, 78 research that was results that were exposed to the people, to the attendees. And when you look at the number of this research coming from monocentrics, means only one hospital, not joining efforts, you see that the high number of this abstract came from experience from one center to or two. And as you can see, the mean number of patients range from one case. So of course, to report one case is important, since one new case can bring new data, new idea to go to the research. But a report on one single case is very difficult to take conclusion for care of the patient, of course. And if you look at the multicentric, it was only 14 multicentric abstract studies presented here, but it represents more than 2,000 patients, more than all the other monocentric. That's why for very rare disease, such as esophageal atresia, there is an absolutely need to join efforts and to put all people together to try to have better information, better data, and reach to common consensus or common way of taking care of this disease. So one way to go on is to join everybody was to create in 2013 what I show you as very recent efforts. This started less than 10 years ago when people think to join their effort to go on. So this international network on esophageal atresia is a completely informal network. No fees to pay. It's only people, multidisciplinary people, nurses, speech therapists, surgeon, pediatrician, neonatologists, pulmonologists, adult doctors, very few adult doctors. We already speak, it's difficult to have adult doctors on board, but more and more are joining, interested in this disease and putting all their effort together to try to solve some question. And so we had a steering committee, and from now the number is increasing, and as you can see here we have 200 and more than 270 members, but if you look, there are pediatric surgeon, pediatrician, nurse, parents, genetician, psychiatrist, psychologist, so meaning that taking care of a child with esophageal atresia needs to have a multidisciplinary approach. And if you look at the countries, the number, we have almost all the countries or most of the countries on the world joining this network. And we have two major objectives with this networks. The first is to reach consensus on the care of patients. Until now, there are no international consensus about the care of the esophageal atresia patients. And also to organize every 2 years or 3 years an international meeting where people are meeting all together, sharing ideas and starting projects together, and to know better what happens in the country or how outside or in another city is very important to put together our experience. The first guideline is that was been published and has been published. You see, it's very recent. It was just last year. I will just spend a few minutes explaining how does such a consensus needs on time and investments. It's not only sitting with 6 experts around the table and say, yes, we need to do an endoscopy at the age of 6 years, and we need to give PPI for the first years of life. It's a professional, complex process which have specific rules. So the first is to look at the literature, what has been published about the topics, and then to look carefully at the quality of these studies. Is a study good enough to be, for the result to be taken into account, or is it only a retrospective report of 2 cases and we cannot reach any conclusion about that? So classification of this study is needed. And then we have to select a question. What are the questions really important to solve? One of the questions, for example, is where to go for a fundoplication in esophageal atresia. When to test for gastroesophageal reflux, when to test for dysphagia, what are the best treatment for an esophageal stenosis. So very practical question, and we reach a list of 41 questions to try to answer. And then people are looking at all the literature, writing proposal, meeting, discussing, voting, and finally reach a consensus. What I have to say is for esophageal atresia, 41 questions, so it's 41 statements, and these 41 statements at the end were expert opinion, since we had 2 large prospective series or studies to reach real evidence-based consensus. So we hope that the update of this, it will be changed at the first step. It gives some advice, some point to follow, but that will change with time and with better study answering most of the question. So that's the first guideline is published last year. This year, a very difficult and very long timing discussion is about what is good definition of a long gap esophageal atresia. I'm not a surgeon, and there are several in the room, so I have to be careful in speaking about that. But what I know, at every meeting in France or outside where we speak about long gap, surgeons were upstairs on the table and fighting against 3 centimeters, 2 vertebrae, not able to reach an anastomosis in the first week of life, and no, it's type 1 or it's type so. And so we were very happy to have this year a position paper. And of course, it's not evidence-based, but it gives some steps, it gives some points for people speaking the same language. And if you look at literature at long gap esophageal atresia, you will find as many definitions for long gap as there are of paper. I'm a little bit excessive in my talk. So, following these guidelines, we can speak all the same language and compare different techniques and to improve the care of the patients. And the third consensus is going on. There is a nice group of 11 of 12 ENT doctors and pulmonologists writing from now guidelines about pulmonology care of the esophageal atresia patients. So we are quite happy to reach this consensus. They will move with the time, but putting our effort together can reach to at least one starting point to go on with the care and research, of course, on this disease. So I said that one of the goals of this is also to organize the meeting, and so please take your agenda. I know you are much welcome at the next Esophageal Atresia Conference. It will be organized by our colleagues from Jesus Bambino from Roma, who are expert in the field, with both a surgeon and pediatric endoscopist. And it's just to show you that the story is start in 2010, and then we had a nice meeting in Montreal. It changed every time with a new organizer. And then it was in Rotterdam, so last year in Sydney, and the next will be in Rome. And this is a place for people, and family support group are present at the last Sydney meeting. There were lectures given by family support groups. There were round table where families give their advice on things. So people are working now more closely together, of course with respect of each specificity. Parents are not doctors, doctors are not parents of the esophageal atresia child most of the time. Other initiative has been taken I'm pediatric gastroenterologist, have been also taken by European Society of Pediatric Gastroenterology, Pathology and Nutrition, which support an esophageal atresia working group. So it's of course more focused on digestive, but I just want to show you what type of research can be supported and why we need to be together, to be international, to have many centers associated to answer the question. As an example, and this morning there were questions about eosinophilic esophagitis in esophageal atresia. We don't know really yet if it's by coincidence or by the fact that we do a lot of endoscopy in this patient, a lot of biopsies, that we seems to find more esophageal eosinophilic esophagitis. So there is a project by Usha Krishnan to have a database, an international multi-center study. But as you know, esophageal atresia is very rare, and in this rare disease, eosinophilic esophagitis is even more rare. So to reach enough cases to understand what is a natural story, if eosinophilic esophagitis is decrease or has any impact in the patients, we need to have a lot of patients. So to have a lot of patients, since it's a rare complication, we need to have a multi-center study. It's not possible for any center to answer this question. A second question is, that's just example to show you why we need to be together in such projects. The second question was asked by Luigi Dall'Oglio is, what is the best dilatation technique? Is it balloon or bougie? It's from now, there is no answer, no study available in literature comparing these two techniques. And so what is important for us is, of course, efficacy. Is the dilatation restore a normal esophagus, but also to avoid perforation and complication. And when you look at, with statisticians, how many patients you should include in such study to answer the question, you reach 1,000 cases. So 1,000 cases of esophageal dilatation is absolutely impossible to have even at a national level, or you have to wait for 10 years or 15 years. So putting the effort together, putting people around the table could answer within a reasonable time, 2 years, 3 years, what is the best technique for dilating the patient. So that's only, of course, example. The last initiative I want to discuss is very recent. It was a European Union initiative which launched a call for ERN. ERN means European Rare Networks. So thanks to the pressure of different lobbying, and family association are one of these lobbying, and also doctors involved in rare disease, the European Union wants to push people to work more together and to create network. So there was a 21 network created, and one of the network called ERNICA is about rare digestive disease, including short bowel syndrome, Hirschsprung disease, congenital diaphragmatic hernia, but also, as you can see here, congenital malformation of the esophagus. And so, you see also on this slide that European processes are quite complex, with a lot of steering committee, medical committee, working group, work stream. But at the end, it's starting, it's just the beginning, it was launched last April of this year. So groups are starting to decide. And when you look at the first year priority of the work stream about esophageal atresia, the one is for standard of care to try to define a core outcome set for esophageal atresia. Until now, we go to, for example, the outcome is a number of dilatation or gastroesophageal reflux. But what we want to reach is a common set, asking nurse, parents, doctors, neonatologists, what seems you important to follow, what is the important outcome. It's perhaps not pH metry results, perhaps it's quality of life, or perhaps it's full feeding by mouth. So we have to define these criteria, to have a common criteria, what is a good outcome for a child. The second goal for this year is to try to train the youngest doctors, and there will be next November a 2 days training session in Finland, in Helsinki, where young surgeon, young pediatrician can be together and be trained in surgical techniques, endoscopy techniques, pulmonology, and so on. The program is very close to your program here, but it's for young doctors to be trained for the future. And the last point is very exciting one, is to validate a specific instrument for quality of life in esophageal atresia. There have been a lot of work doing by the Gothenburg group in Sweden, where they validated a specific quality of life instrument for child age 6 months to 6 years. And it is validated, it's perfect, but it's only in Swedish and in German. So it's very difficult for French, for UK people, for Spanish people to use. So since ERNICA is international in Europe, our goal here is to validate the translation. You have to be sure that the question asked in Sweden are the same, are understand the same by a French mother or a Spanish father. So that's the 3 priority, but of course, within this network, there will be, we hope there will be, a lot of opportunity for research, sharing sharing protocol, writing recommendation to help the life and the care. So just at the conclusion, all these initiatives are recent. We are less than 10 years. So it needs time, of course, to reach results, but there is a strong willing, a strong initiative. This is a very great opportunity. We are very enthusiastic about this initiative, but there is a warning. We need to really coordinate and pool energy and not redo in every of the structures the same things.